Hi, I'm Robert McClay, MD, PhD, ETC, and welcome to Lecture 1 of my MD, PhD, ETC series, which, since I'm a psychiatrist, is about psychiatry, what it is the heck we do, in the grander scale, like why are we here? And in doing so, I'm going to talk about the nature of psychiatric illness, the difference between disorder and disease, reflect on sort of what's the difference between psychiatry and psychology and all the other disciplines involved, and how we, in the end, hopefully end up actually helping people. Because, I mean, hopefully that's the goal of all of medicine and the associated, disciplines that work with it. But in getting to this, it's really important to sort of understand the concept of disease, because the short answer for what is a psychiatrist is it's a physician who treats mental disease or mental disorder. But the question then comes up, well, really, are there any mental diseases? Is that a real thing? Certainly seems like something like schizophrenia or certainly Alzheimer's seems like a disease. But then you get into depression, anxiety, oppositional defiant disorder, and people start to go, that just seems like sort of a version of normal behavior, maybe not so functional. But is there really something wrong with someone's biology? Is this the same as, influenza, which you would go to a doctor for? Why are you going to an MD at all for the problems in your life in that regard? And there is a distinction here, because when I say it's MD, PhD, ETC, in my background, psychiatry is sort of unusual among medicine, in that there is clearly a medicalized part of this that we give out, medications, pills, that we do medical procedures like electroconvulsive therapy or transcranial magnetic stimulation, even psychosurgery for obsessive compulsive disorder. But on the other hand, we talk about a lot of these problems, which doesn't seem something that you normally go to a physician for. Why are you just chatting with someone? And there is a spectrum there, in that there are conditions where it's hard to say that this is truly an illness in that regard, and there is a question there about the spectrum. If you take this outside the field of mental health, you could look at something, say, like dwarfism. When does becoming short become an illness? It's clear that at some examples of this, say an achondroplastic dwarf, that there's a particular genetic mutation that leads to this. If you're below a certain level of height and stature, but your lifespan is clearly quite limited because your lungs aren't big enough, your heart, has a difficult time functioning in this compressed environment. The opposite is true, by the way, at the other end of the spectrum. If you looked at a giant, you have someone with acromegaly, that they're clearly producing too much growth hormone. Normally, a lot of us would like to be bigger, taller, but if you get too big, that your lifespan is very clearly limited. So where does that become a disease? And this becomes important in terms of the medical model to some extent, because we have had this agreement in society that we have insurance and we have public health institutions to take care of, quote, mental illness, because that's not someone's fault. And clearly, many of these conditions can be debilitating or even lethal. Something like anorexia, which sometimes gets sort of made fun of as just being skinny models. It's very different, by the way, has a mortality rate that is actually similar to that of leukemia. So, mental illnesses can be very, very serious, very debilitating. You see homeless people on the street who previously, if you talk to their families, these were smart, capable people who are completely debilitated by their mental functioning. You see veterans, which is a big population that I work with, people who have lost limbs, and yet they are more impaired by the mental struggles that they have than by the overt loss of a limb. So there's clearly a medical component to it. But there's also this sort of more vague thing where, knowing about Shakespeare can be as important to helping your patient or your client as all the physiology and neuroscience and that sort of thing that were studied. So, and there's a split between how we do things. So psychiatrists, to make clear, are medical doctors. They're people who, after undergrad, did 4 years of medical school, who studied the same anatomy, physiology, pharmacology as any other physician. Spent the 100-hour weeks in med school, and can be a pretty brutal experience. Med school, there are some work hours now, and people of my generation still are like, "You kids have it easy," but in general, medical school, it was a big struggle. There's a lot to learn, and there's a lot of medical information that we get. And then after that medical school, a psychiatrist will do 4 additional years of what's called residency. And pretty much these days, all physicians are going to do a residency. So after a physician graduates from med school with sort of a generic background, we do rotations in a lot of different specialties in med school that somebody will specialize. And this is really where physicians get their feet wet, where you're actually treating patients and doing often the bulk of the work in a teaching hospital, but under the supervision of more experienced physicians. It's an apprenticeship, basically. And again, it's often quite brutal. When they first put 100-hour per week limitations in place, a lot of residency says that we couldn't possibly function that way, particularly surgical residencies. It's now capped at 80 hours a week, but pretty much 80 hours a week for 4 additional years in any residency. Psychiatry is not as bad as, say, surgery or OBGYN, which is often considered the most brutal. But it's a very intensive learning environment where in psychiatry, we're learning specifics about medications to treat mental illness, how to classify them, how to identify them, learning not just the medications, but therapy, other modalities that can help in that regard, learning all the parts of how you treat someone who has a mental condition. And this differs from a psychologist. So psychiatrists sometimes get a little snooty about the fact that psychiatrists and psychologists are sometimes confused, as they do sound similar. But a psychologist often can be someone also who has a lot of training. The psychologists, instead of going to medical school after undergraduate, will go to a specific training program. Some of them have just a master's degree, a minimum of sort of 2 years. But often people will get a PhD, a 4 to 6 year degree, or a PsyD, which is also, again, a 4 to 6 year degree that's focused just really on therapy and psychological testing. With the PhD, they split off into sometimes experimental psychologists, which really is almost indistinguishable from neuroscientist. That's what my PhD is in, by the way, is neuroscience. To a clinical psychologist who is really working on how to help patients. So a psychologist, in doing those additional 4 to 6 years of training after undergraduate, is really learning how to do therapy and how to do psychological testing, which are things like the Rorschach tests, bubble tests, IQ tests, things like that, that really help us narrow down diagnosis, which gets to the larger question of what the heck is diagnosis in mental health? Because sometimes, particularly for psychologists, they may not be so focused on that. If you don't care about an insurance company or anything like that, so you may go back to just being like, how do I help this person? How do I understand this person as an individual and what they want to accomplish and be working towards that goal, regardless of diagnosis? But psychiatrists brought into the mental health field the idea of the medical model. Freud was an MD, a neurologist by training. So what is the medical model, and how does this apply to the idea of mental health? Well, the medical model is that we identify particular diagnoses and that diagnoses lead treatment. that if we can identify a problem and define it very precisely, this can give us a lot of power over understanding how we can help somebody with this condition. And physicians have been doing this for hundreds of years, way outside the field of psychiatry. So, to use the example of the flu, physicians have been treating the flu for hundreds of years. The thing is, we didn't always know that the flu was caused by the influenza virus. This was effectively a syndrome that was named to begin with, that physicians recognized that people came in, usually in the fall and winter months. They had high fevers, body aches, some breathing difficulties. It looked different than a cold, more severe, and they called this condition the flu. And a lot of those just collections of symptoms are now sort of clustered into what we call flu-like illnesses, because not everything that looks like the flu actually is caused by the influenza virus. But what defining this allowed us to do was to take, okay, all these people that have these symptoms, what do they have in common? Well, antibiotics don't seem to help them. That's one of the things. And when we look at their blood, we can't find other particular causes, but hey, there were these little particles that we could see in electron microscopes, and it had turned out to be the influenza virus. And we discovered when we take that virus and sort of exposed animals or other things to it, they developed flu-like symptoms. And when we developed vaccines to block that virus, that these symptoms went away. So this allowed us to actually realize that the syndrome of the flu, the disorder of the flu, was actually a disease. As a disease is basically that syndrome, that disorder that is caused by a particular biological issue. When we get into psychiatry, we can think about the difference between Alzheimer's dementia, which is something that a psychiatrist can diagnose and treat, versus Alzheimer's disease, which is something really only a pathologist can diagnose. It's something that's diagnosed post-mortem. Because when you slice someone's brain, you can see these particular amyloid plaques and tangles that indicate that all the dysfunction that you saw leading up to death were caused by this mess that's going on in the brain. But until then, presuming we haven't sliced somebody's head open, and the technology is not quite advanced to the point where we can see these with non-invasive things like fMRIs, and there's some movement towards that where the line is getting fuzzier, but bear with me. Really, Alzheimer's disease, to know that, you've got to be able to look at someone's brain. But we can be able to define that syndrome, to be able to say, okay, that there's a pattern of this memory loss, that it is slow in onset, that short-term memory starts to go first, that other areas of function start to degrade. And we can define that syndrome in a particular way, the way that physicians defined the syndrome of the flu 100 years ago. And we can call that Alzheimer's dementia, not the disease, but the disorder in that regard. And we can do that for a number of other syndromes. We can say, okay, well, some people come in depressed, some people, just spontaneously recover, but we've noticed that there's a certain group of people who just don't seem to get better. Well, let's narrow that down. Let's try to notice what that they have in common, the people who don't get better, and define a particular syndrome that we're now going to call major depressive disorder. We're going to create this checklist of symptoms and really try to narrow this down very specifically, and therefore say, when someone else comes into our office, I can say, your depression, when I talk about major depressive disorder, really looks like this particular syndrome. And how is that diagnosis useful? Well, based on that, I can tell you, well, your depression looks like that of these hundreds of thousands of people that we have studied throughout the world. And we can tell you, with them, we generally know what happens. We can tell you that based on this, that there is about a 2/3 chance that your symptoms are going to continue for at least a year if we do nothing. That if I look at you again in a year, people with this particular pattern of depression, generally only about 1/3 of people are going to get better on their own. Vice versa, I can tell you that if I give you this particular medication, that you have about a 2/3 chance of feeling better. Or if I do particular forms of therapy, and a lot of different forms of therapy work in the case of depression, but there are other syndromes where it's like, oh, only this particular type of therapy really works. That if we say obsessive compulsive disorder, if we just talk about it, blah, 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 you're not likely to get better. But if we do something very specific, exposure therapy, you're pretty likely to get better. So we can both look at the natural history and tell you what's likely to happen if we do nothing. And we can also start to guide treatment. Again, that idea that diagnosis drives treatment. And this is why psychiatry is a medical field, is that psychiatry is, first of all, trained as MDs, but also we have taken that training, and even someone like a psychologist who was trained in a different way of thinking, never went to medical school, is going to end up using the same overall model. Is going to try to give a diagnosis, and then all the other specialties that come in, our nurses, our technicians, our social workers, are going to be able to do their part based on the idea that we have a diagnosis. Now, the question does come up, is just because there is a diagnosis, does that mean that there is disease? Again, a reminder that disease means a particular biological cause leading to a pattern of symptoms. And the short answer is no. Essentially, we already know that a lot of our disorders are not really one thing. To look at the example of depression, there's this idea that quoted as a serotonin deficit. And the way that we came to that idea was simply put that people with major depressive disorder tend to get better when you give a medication that increases serotonin. But does that mean that everybody with depression has a serotonin deficit? Because if I sample out of your cerebral spinal fluid, the fluid that bathes the brain, and you can also goes into the spinal cord, which is where we can get samples of it. If I look at an individual, I'm not actually able to tell whether they have major depressive disorder based on their serotonin level. If you take 500 people with major depressive disorder and 500 people without, I can tell which pooled sample comes from the depressed people. But the issue with this is a lot of variation in humans. So what your individual biochemistry says is not necessarily going to define your symptoms. So there's a lot of variation there. Also, within there, the depression doesn't instantly get better when we add the serotonin. So there's more to the biology, clearly, than just increasing serotonin levels. But the really big giveaway is that treatments don't work all the time. Even if it was something downstream from serotonin that really is sort of the primary cause of this, and it was one unified disease, still, if it was one thing, everyone should get better with one treatment, and they clearly do not. You have about a 2/3 chance of an antidepressant working, but that still means that a third isn't. So what's different about those folks? And also, different antidepressants work. That some of them increase serotonin, but others increase related biochemicals, norepinephrine or dopamine. So those 3 different types of depression, the symptoms don't seem to very clearly correlate with this. So we know that there probably are a number of, quote, diseases within the larger disorder. Even for something that seems very clearly like a disease. Anyone who has ever talked to a schizophrenic, I think, would have a difficult time saying, well, this is just how they are. This is a variation of normal human function. It's schizophrenia. The misnomer is it means split personality. It doesn't. It means the splitting of the self, in that there is this dramatic personality change that a person that a person has, where they really become quite different than the person that they used to be, and usually in a very negative way. They hallucinate. They're tortured by this. They often become paranoid. It's a horrible condition to suffer from. I wouldn't wish it on anybody. And the other word for it used to be dementia praecox, the dementia of the young. So if you think about Alzheimer's being the dementia of the old, schizophrenia was the dementia of the young. But we never found the sort of brain pathology to explain schizophrenia that we did for Alzheimer's. If you slice up a brain of someone who has passed away who had schizophrenia, it's going to be very hard to tell that there was anything different about them, unlike somebody with Alzheimer's disease. So does that mean it's not a disease, or does it just mean we haven't dug deeply enough? To some extent, it doesn't matter, because, again, to get back to why are we here, we're here to help people. And we're using the medical model to help people, but that doesn't mean it's the only way that we can do it. So beyond just doing diagnosis, which is one way to approach, I talked about that psychologists sometimes don't worry about that as much, or maybe social workers don't worry about that as much because they're trying to figure out somebody on an individual level. And of course, we always want to do that, even for, a physician in a different specialty. If I'm treating your flu, I still should get to know who you are and, why it is you're likely to take this Theraflu or why you're not. In that regard, and different aspects of your life could influence it. So it's very helpful to understand somebody on a more personal level. And this is where a lot of therapy comes in, but also in terms of, well, how do we lead treatment in that regard? Well, there are lots of different ways to figure out a person. What in psychiatry, the psychobabble word is to formulate someone, to figure them out. But one that I think is particularly useful in describing how it can lead to treatment is the biopsychosocial safety model. The idea that you can break apart somebody's life in the different modalities that we're eventually going to help them. So we can look at the biological part. We can say, okay, again, their diagnosis fits this, but also say within that biology that they have a family history of this particular condition, and their aunt responded to this medication. So therefore, we're going to use that biology to guide the particular medication that we're going to provide that individual. Psychologically, we're going to try to get inside this person's head and talk about, well, what are their inner conflicts? How do they talk to themselves? And is that reinforcing what's going on here? Because talking to yourself really does change how we think and how we act. And in the end, it also changes brain biochemistry. We often think about the medications coming in and changing out, but it goes in both directions. Because in the end, I am a pile of biochemicals, and everything I receive from my environment is received that way. And we can see that in something as simple as if you take the cerebrospinal fluid of people who just won tennis matches and the cerebrospinal fluid of people who just lost tennis matches, the people who just won will see their serotonin level go up. There's a biochemical effect of the external world and on the way we talk to ourselves. But going into that external world, that's the social part. That all the antidepressants in the world might work perfectly, but if you're in an objectively miserable situation, are you really going to feel better? And there may be practical things that we can help in terms of your social situation. If you're homeless, maybe we can help you to find a shelter. If you're being abused, maybe we can help you get away from that person. If you're starving to death, maybe we can help you to find a way to apply for government income, to apply for jobs, that sort of thing. So each one of these parts of ourselves, the part that we can clearly identify as biological, the part that we can identify in terms of the way that we think about things and talk to ourselves, the external stresses that we can look at, can we intervene in that way? And arching over a lot of it is also this fourth part, safety. Can we make sure that you're going to make it to the next appointment and be able to take advantage of that biological, that psychological, that social intervention that we're going to offer? Because if you were dead, nothing's going to get better. And sometimes your brain does try to kill you. So if someone is acutely suicidal, we have to first stop them from killing themselves. If they're going to be violent and would end up in jail and someone else would get hurt, we need to stop that. If they're so impaired that they just can't take care of themselves, we're going to need to intervene. And that's where the hospital comes in. And I'll do a whole separate lecture on the psychiatric hospital and how that can be helpful. But in the end, the basic message of what I want you to take away from how psychiatry works and what psychiatrists are is that we are physicians who treat mental illness, but who try to treat the larger person as well. That there are two ways that we approach this, that we use the medical model to try to identify particular patterns, and then you can use that pattern to look up what tends to help for that pattern, but also that we're going to do a deeper dive and try to really understand someone on an individual basis and use that individual basis to try to figure out how our patient, our client, the person we're trying to help, can really lead a better and healthier life. So one thing I wanted to make sure I added, and I'll try to splice this part in, is that one important thing to realize is that a person doesn't have to be crazy to see a psychiatrist. Now, we do sometimes treat severe mental illness, people who hear voices, lose touch with reality. That is part of what we do. That is the sort of place that I'm working at tonight. But I also work in an outpatient clinic where I work with very high functioning people, people who could be described as supermen in a lot of places, special forces people, that sort of individuals. People who have accomplished amazing things in their lives, but are having an issue that blocks them from that. Now, again, usually according to the medical model, we have to identify a particular diagnosis. That might be minor, might be fear of heights. It might be something that no one believes is a biochemical abnormality. Oppositional defiant disorder. Sometimes people describe this as a stubborn child. And someone says, well, are we medicating kids because they're just normal? And the short answer to that is no. That definitely people come to a psychiatrist, and there are plenty of things we don't medicate. We would never believe that we should medicate. We don't think this is a biochemical abnormality. It may simply be a recognized problem. That this is a common issue that we've identified as causing social and occupational impairment. From the medical model, we do have to identify that. We do have to say that there's some level of actual impairment for insurance companies to want to pay us. But sometimes on a cash basis, or working with a psychologist or other forms of therapists, there are plenty of people who also come to see us just because their life is not quite where they want it to be. They haven't been able to finish their next book or something else like that. So we do go outside the medical model, and even within the medical model, that seeing us does not mean that you're severely impaired, that we treat a broad spectrum of options, and these overall tools that we use are still helpful regardless, and hopefully we're helpful to our patients in the process.